everyone. We are at HIMSS 2018. This is David Harlow bringing you dispatches from the front, from the exhibit hall. I am here today with Whitcom, who is the Chief Medical Officer of Remedy Partners. Welcome, Win. Thank you for speaking with us.
Great to be here, David.
So Remedy Partners has a program going helping healthcare providers participate in CMMI innovation programs. Particularly, we've been talking about the BPCI program, and I wonder if you could tell us a little bit about that program and the way in which that you're helping folks participate.
Sure. First, I'll say that Remedy Partners is really an episodes of care or bundle payment company, and we've built an end-to-end solution to support patients and providers who are managing episodes of care. As it relates to the bundle payment for care improvement initiative, that's what you were asking about, the initial BPCI program, correct?
Right.
That's something that we've been a convener through this program with CMMI and CMS. And we went live with our first program in the fall of 2013. And since then, we've managed about $12 billion of medical spending in that program, representing about 500,000 episodes coming through that. In all 48 episodes, so that program has 48 different DRG-based or diagnosis-based episodes. And we've been working with many hospitals, physician groups, including hospitalists, orthopedic surgery groups, cardiovascular medicine groups, and also skilled nursing facilities and a couple of home health agencies, all of which are the risk-bearing entity in the program, managing patients through an acute illness and then the recovery from that acute illness. And that's really kind of what we're in the business of, is supporting health systems and providers to better coordinate and take care of patients as they go through an episode and recover, hopefully at home.
So do you see the greatest opportunity at the point of handoff from one provider to another, or are there opportunities within a provider, within an inpatient or nursing facility setting?
Yeah, I think it's actually both. Really, the opportunity with bundle payments in general and BPCI in particular is creating a coherent experience and a cohesive, coordinated experience for patients as they travel through an acute medical or surgical illness and then recover from that illness, regardless of the setting. And traditionally, we've had a lot of silos between the hospital and the post-hospital setting. What BPCI does, it creates, through a single payment for an episode, it creates an incentive to coordinate care as patients transition from hospital to post-hospital. And then within settings, whether it's the acute care setting or post-acute facility, post-acute in the community, to create an incentive to take out essentially low-value care that doesn't improve somebody's chances of having a good outcome. So as it relates to your first question around care transitions, very much a premium on doing a good care transition between all of those settings in an episode and all the elements that one would think of as a good care transition. Information flow, good handoffs, scheduled appointments, checking in with patients, all of that stuff. But then when patients are in, especially post-acute institutional settings, there's a lot of opportunity to drive value up in care in those settings and to, for example, right-size length of stay in many skilled nursing facilities, big opportunity to do that well, and a big opportunity to improve quality as well. And the last thing I'll say is that those providers, like we'll take an orthopedic surgeon or an acute care hospital who may not have had line of sight for 90 days after a hospitalization, now there are incentives to build systems to create that line of sight so that they understand what's happening to their patients after they leave their setting and then go on to recover elsewhere.
Well, they're certainly incentivized, and the question is whether they do have that line of sight and that level of control in order to realize on those incentives. You mentioned conveners. Who is your typical point of contact as a convener for such a project? Is it someone within the hospital? Is it a physician leader, or who?
Well, so in terms of point of contact for Remedy, who is, you've said, a convener in BPCI, we'll usually have multiple points of contact. Clearly for success, and I'm not sure if I'm answering your question directly, clearly to succeed, the main point of contact needs to be a leader in a provider organization who's taking risk in the program with us, what would be known as an initiator. Critical success factor in BPCI and any value program is committed leadership. But we also have points of contact more at the managerial level, so there will invariably be somebody who's coordinating the program, all the moving parts of the program. That could be at a hospital, it could be a director of performance improvement. They may even have a title, a bundle payment or value officer role. In a physician group, it's usually going to be a combination of a physician leader and an administrative person if it's a large enough physician group, although some physician groups just have physicians, and perhaps even in a smaller group they may just have a coordinator level person who's doing things like, in terms of operations, building that patient list every day so the physician knows, who are the bundle patients in the program today.
Great. Well, there you have it, bringing the human factors together with the technical tools. I've been speaking with Whitcom, Chief Medical Officer at Remedy Partners, about the BPCI program and Remedy's tools. Thank you for joining me today. This is David Harlow, connecting at HIMSS 2018.